Hello, my name is Samir. I'm a fifth-year PhD candidate in Dr. Alex Bouie's lab. And today I want to talk to you all about some work I've been doing looking at detecting symptoms of depression using consumer wearable devices, namely the iPhone and Apple Watch. So the way that I got into this field was because I track everything that I can. I got my habits, got nutrition, got multiple wearables, Bluetooth devices. And for the most part, it's not that useful. I do it because I'm a data nerd, but there isn't, I think, a lot of specific use cases for these type of data. But in particular areas, I think this data can really shine. For example, I have sleep apnea, and it's a condition where effectively at night, if I don't have a machine breathing into my nose, I will wake up multiple times a night. And what I notice every once in a while on my Apple Watch's heart rate monitor is at like 3 a.m., I'll have an elevated heart rate that shouldn't be there. And because I know I have sleep apnea, I can do something to kind of correct it. And so in this case, my mask was just kind of loose, fixed that, and I didn't get 3 a.m. spikes in heart rate anymore. I've also been able to like improve the way that I kind of push my body and how much energy I expend based on my rest, and learned just how bad alcohol is for me, which is not good. And so in these situations, when we're looking at using wearable device data, there's two key assumptions that we want to be able to hold. The first is that there is clean and consistent input data. Unfortunately, that is not true. Looking at some of my own data, for example, from the Whoop band, which is a wearable device, as well as the Apple Watch, another device. On the right is a graph showing sleep duration over the period of about a month and a half. And while the Whoop band and the Apple Watch are giving similar results, they are not the same, and there's definitely significant outliers. And so that first assumption of like clean data does not fully hold with consumer wearable devices. The second requirement would be having some type of well-defined outcome. In the example of my sleep apnea, that was, I knew that I had sleep apnea and what a elevated heart rate could relate to. However, in looking at mental health, we see that this also doesn't hold true. Major depressive disorder has one of the poorest inter-rater reliabilities, even when clinicians are diagnosing it. It's very low, and there's a famous research in the field tweeted about how it's barely above chance level, as shown in reviews. And so we're in the situation where we're trying to map really messy consumer wearable device data to a full diagnosis that isn't fully understood, at least mechanistically. And we see this kind of reflected in the literature. There's a lot of studies that have taken relatively low sample size of participants, monitored over the course of a couple of weeks, up to like a month or two, and found some significant associations between features derived from these devices and things like depression severity. However, they often use things like different devices, different features, different ways of generating those features, and the associations they find are very weak. In addition, when you're looking at any of these associations, often their directionality will change between different studies. So for example, increased total sleep time might be significantly associated with depression severity in one study, whereas decreased total sleep time is significantly associated with depression severity in another study. And so there isn't a clear understanding of how these data map consistently across devices and participants. And one of the reasons for this kind of goes back to a framework that David Moore and colleagues had put together, figuring out how to map this raw sensor data to clinical state. In general, a lot of studies are pretty good at going from sensors to some form of low-level feature. There's some established pipelines for these. There's definitely room for improvement, but I do think this step is done somewhat more consistently. However, a lot of the studies that we do tend to skip the in-between step. We go from low-level features all the way to directly predicting clinical state, missing a lot of these high-level behavioral markers. And so what I'm trying to do is use the features we generate to detect symptoms of major depressive disorder, and looking specifically at some of these behavioral markers. So in practice, a lot of what this work is looking at is taking wearable device data, mobile health data, aggregating it over a time period, and comparing it to answers to a survey. The surveys that I'll be talking about are about depression, measured by the PHQ-8 or depression severity, anhedonia, which is measured by the positive valence system scale. Anhedonia is one of the key symptoms of depression related to a loss of pleasure, and it is also associated with treatment-resistant depression. And then finally, looking at sleep quality, one of the factors that's very influential to depression severity and progression. And so when looking at these data, I'm trying to ask the question of, for every survey question, how does the mobile health data relate to it? And so I'm looking at individual responses and not just the total scores. This data set that I'm using is from the Optima study, which is a 13-week study where participants have wearable devices and iPhones and are monitored over the course with self-report surveys, the digital phenotyping, battery of different self-reports, and at the end, they're given neurocognitive assessment as well as MRI scans. The patient population we're looking at has a varying degree of anhedonia, that symptom that means loss of pleasure, as well as varying levels of depression. Also, feel free to stop me and ask any questions in between as well. Looking at the population, we are studying 133 participants in this data set. However, this is an in-progress study, and so there are more participants now, but at the time of analysis, it was 133, and you can see that they're at different levels through the study. Most have completed it at 13 weeks, but a significant portion are still within it. They have a range of anhedonia scores as well as depression scores. And looking at their demographics, I want to point out where this data actually applies. What we're trying to measure is behavior from these wearable devices, and that is very population specific. We have a relatively decent range of ages represented between 20 and 60, a spread of currently endorsed gender. However, for family income and race, it's heavily skewed wealthier and white. So moving on to the actual pipeline and what we analyzed. So the way I started is by taking phone and watch data and aggregating that data into features prior to the self-report survey. And so we're trying to relate, like, for example, for the PHQ-8, the measure of depression severity, that questionnaire asks about the prior 2 weeks. And so I aggregate 2 weeks of heart rate, respiratory rate, et cetera, before that questionnaire, and then use a machine learning model to predict that response. And so the classification algorithm I use is called gradient boosted classifier, and it's trained using a 10-fold grouped stratified cross-validation where participants in the training set are not in the testing set. So what could we actually predict? First off, we were able to detect depression severity, the total score from the PHQ-8. And here the metric I'm showing, ROC AUC, is a measure of performance for binary classification models. Looking more at the item level responses, so those individual symptoms, we were also able to detect poor appetite. And this one is a symptom that I'll go into more detail of, but is interesting in that it's typically assessed alongside increased appetite. Normally the PHQ-8 combines those two in a single question. However, work from Dr. Cohen and others created a version of the PHQ-8 that split the items that normally have two directions into different questions, so we can actually check which direction of the symptom are we able to detect with these devices. From sleep quality, we were able to detect their actual bedtime relatively well as if they were having trouble staying awake. And for anhedonia, the PVSS, this questionnaire actually had the most questions and subscale scores. However, we were only able to significantly detect one item, which was a fun activity during the weekend sustained by good mood. One theory for this is it's a question where there's a very strict temporal component. It's asking about the weekend, and we have features related to that type of activity. And so we're getting like energy expenditure over a weekend. And that seems to be one of the things driving performance for this model. And so I did say we're going to go a bit deeper into poor appetite. And so poor appetite seemed like a feature that might have a relatively stronger physiological signal. For example, when someone is fasting, their fasting is not eating food, their baseline heart rate actually averaging across the day is lower. I notice this when I'm doing days where I don't eat, and I have a very, very low heart rate throughout the majority of the day. And we're seeing things like vital signs being picked up as important features. Plotted here is a measure of feature importance, the SHAP value, where the actual absolute value represents how important it was to the model, and the direction influences whether it was um, like influential for a negative decision, so classifying it as a 0, or positive on the right, classifying it as 1. The color here shows how high the actual value of the feature itself. So was it a high heart rate that contributed to classifying an answer as positive? Would be in red on the right side here. I wanted to also see which subpopulations did it seem to do the models appear to work better for or worse for, and didn't see any difference across ethnicity, Hispanic, non-Hispanic, as well as current gender and family income. However, there was a difference in performance across those who had high depression versus low depression, as measured by the PHQ-8 with a score greater than 8. And that was specifically for the anhedonia question, looking at whether a fun activity during the weekend sustained good mood. Those with low depression severity actually had a better performance from that model. So I kind of wanted to go back to this question of why can't we detect more anhedonia or sleep quality items? A lot of the items we could detect were from the PHQ-8 related to depression severity. One reason might be that the feature space we're looking at is pretty limited. In this study, I only look at vitals type data, like vital sign type data, and physical activity. We get a host of other data from these devices, including social related behaviors, location data, how people are typing on their keyboard, as well as environmental factors like ambient noise and ambient light. In addition, the relationship between your wearable device and phone metrics might just be more complex than we can model with 133 participants. And while that's a larger sample size and studies often done in this field, it still might be too small for the relationships we're trying to model. And I guess to summarize, I do think this shows preliminarily that mobile health data can help improve our understanding of depression, improve the way we understand how depression symptoms are linked to some of the behaviors. And the technology itself, I think, shows promise. However, that being said, I think we are very far from being able to use this in any trustable implementation for any translational or clinical use. To move forward, I think we do need to do things with larger, more diversified sample sizes. And as the study progresses, we will get a larger sample size. Um, in addition, I think there is a lot of work to standardize how metrics derived from wearable devices across different wearable device types are created, that we can actually bound the error for calculating these metrics and better understand that relationship. And finally, I think there's just room to better understand how wearable device and phone data fits into our understanding of mental health. I think it'll be a different type of information than we're getting from self-reported surveys, but oftentimes the only outcome we have to measure in relation to mental health is a self-reported survey answer. Thank you for listening. Really wanted to give shout outs to people on my committee, my advisor, Dr. Alex Bowie, as well as the co-authors on this work, Michelle Krask, Brunilda Bayou, Zachary Cohen, Amelia Thomas Slavin, and Jonathan Flint. They all helped tremendously with the actual, like, one, creating and thinking of the study, implementing it with the research staff, and then helping me with understanding how to properly contextualize the analysis. Thank you.